Okay, so we continue from here. Head injury. Now, what is head injury? You are saying head injury is an aspect, or let's say it's a condition that leaves the body into a very devastating state. Head injury does lots of things, especially to the brain. You know, in head injury, in short, our main concern is the brain. Okay. So, like we always do, and we did in our first presentation, we are looking at some specific areas and how sharp we can get some questions on neurology generally. Okay, so we are not like picking maybe what is maybe pituitary gland, we'll talk about it and all of that, the anatomy of it and link it to no. All right, so we are focusing mainly on what the NCLEX expects from us. Okay, so we are going to look at instances. We look at the topic where we have to talk about the condition itself. We will talk about and where we'll have to link it to an actual question or a possible question we can get. We'll also link it to that. So talking about head injury, we can talk about lots of things under head injury. But let us see what we have here on this slide. We are saying that an aspect, that's an essential aspect of discharging a client with head injury is ensuring that a responsible adult will check on the client as the level of consciousness can change. So in this case, let me try to cite an example. Let's say in an accident scene, the whole patient or victims involved might be sent to the emergency unit for checkups and the rest. CT scans and, if possible, MRIs may be run for all of them when necessary, okay, or when necessary. There could be a time, you know, if immediately or as at that time, there are no indications for any further management, you might be discharged, okay, you might be discharged home, but an education will be given to you that just in case your level of consciousness change, or we are going to teach you some things that indicate worsening brain injury. Okay, so there are some brain injuries, when you get them, immediately you will not manifest. Okay, you have normal, I think we will meet it in a slide here. We call it lucid period. During the early phase or somewhere in between, you will be fine. Okay, level of consciousness will be intact and everything will be fine. So you will think nothing is happening, but in the next few days, maybe 2 or 3 days, you see a decline in level of consciousness and the rest. Okay. So over here, we are saying that whenever you discharge a patient with head injury, you have to leave the patient with an education enough to be able to recognize decreased level of consciousness or change in level of consciousness so that the person can be brought back to the hospital in time. Okay, and when this happens, you know, the brain swells within the skull, okay, within the cranium. It's the cranium which houses the brain. So, you know, it has a space. Every brain has its own space it occupies in the cranium. When there's an injury and the brain begins to swell, that is where you begin seeing these neurological signs. Okay, your intracranial pressure will rise. So you're going to have increased intracranial pressure. So like we are saying, increased ICP may not be evident immediately. Okay, so the client should return to the emergency department or notify the healthcare provider if any of the following signs and symptoms are present in the next 2 to 3 days. So some of these signs are change in level of consciousness. So at a point in time, you see this patient becoming drowsy. Sometimes it's difficult for you to arouse this person, and there are times of confusion and the rest. Worsening headache. Pay attention to this too. Okay, headaches that do not even go when you take in over-the-counter pain medications. Okay, sometimes too, they get this stiff neck. All these are signs. Sometimes, you see, when they give you confusion or maybe decreased level of consciousness, they think, or they may think you would get the clue faster. So they tend to give you something like headache. Okay, then they will add something small to it. So if you're not smart enough to see, and the history is very important, whether in case study question or a standalone question. Always, you see, most of the questions come in 2 sentences. So always pay attention to the preamble, the history. It always gives you a clue to what the answer could be. So if the person has, let's say, had encountered an incident that maybe involved an impact, whether a free fall or a head-on collision accident or something like that. Okay, when that is your history, and maybe this person has been discharged home after 2 or 3 days, this person begins to get headache, and the rest just suspect. Okay. Any question on the slide before we look at the rest? Okay. If no question, then we continue. So visual blurring, okay, or any visual changes in vision in the eye, it should also give you a clue that the person's neurological health is declining. Then motor problems. When you find it difficult walking, you have slurred speech. There are also signs. Then sensory disturbances, whether with your taste or hearing. Okay, they are also parts. Then you can also get seizures in severe cases. I think for seizures, it will be a sign enough for us to rush this person to the hospital, right? So this is the word they normally use. Sometimes they commonly use headache and nausea and vomiting. So you might think, nausea and vomiting and headache, they are just vague signs. But when you look at the history accompanying the patient, it should give you a clue that it's something neurological. Okay. So you are saying it indicates increased intracranial pressure. This client too is, in fact, supposed to stay away from alcohol. Okay. And we are saying check before taking medications that can affect level of consciousness. So when you have any patient, this one is just a general statement I'm making. When you have any patient who is having issues with level of consciousness, okay, why give, unless maybe we have special cases where you would want to give some kind of opioids for pains, and if there are some seizures, you'd want to give some anxiolytics or something, or muscle relaxants. But generally, especially where we want to frequently assess patient level of consciousness, you don't give any of these medications, opioids, muscle relaxants, and the rest. And when someone, this one is a general statement, when someone is on opioids, muscle relaxants, okay, or any anxiolytics, it's better the person avoid driving or operating heavily machinery. Any question?
Hello, good afternoon.
I didn't see your hand raised up, but you can ask your question
Okay,
anyway.
sorry for that. Please,
Uh,
it looks like I joined late. This is my first slide that I'm seeing, so I want to know what we are discussing, please.
are you in the masterclass page?
Yes, please.
Hey, Annette. Annette, is that you? Hmm. You are doing neurology, okay?
Thank you.
Okay. Any other question? All right. Then I think I have a question for you. But before that, let us, because I think we have additional things to add here before my question comes. We have something we call Cushing's triad. Okay, we used to assess increased level of consciousness. You know, we have lots of triads, right? We have lots of triads. Um, when you know some is better, it makes some conditions easier for you to recognize when you see them in questions. Cushing's triad refers to a set of signs that are indicative of increased intracranial pressure or increased pressure in the brain. Okay, so we are saying Cushing's triad consists of, whenever you hear of the word triad, it means you are talking about three things. Triad, tri means three, right? And these are the signs. Widened pulse pressure. Please understand this. Don't just memorize it because you know how the necklace is. Sometimes you, especially when should you get questions like this in form of case study, you will get the values itself. So you would have to know what a widened pulse pressure is. Okay. You will see, let's say a systolic blood pressure of, let's say, 130 and a diastolic of maybe 50 or 55. That is too widened. Okay. Widened pulse pressure. And sometimes they don't even use the word widened pulse pressure. They can maybe refer to the term increasing systolic blood pressure. So most of the times, what actually causes the widened pulse pressure, or how you will see, is that the systolic blood pressure will be very, very high and the diastolic will be low. So they might tend to mention only increasing or increased systolic blood pressure. Okay. And there are times too, they can also use this word, decreasing diastolic blood pressure. In fact, these two things make up or define the term widened pulse pressure. So take notes of this. And bradycardia, we have bradycardia too, and irregular respirations. Okay, irregular respirations. Sometimes, okay, so you let me leave it like this. Please try and memorize it. So I gave, let's say I decided to put this one here to compare what goes on between increased ICP and shock, the main differences. You can look at the particulars we have here. You see that what you have under ICP, I mean increased ICP, is very opposite to what you have in shock. So what I'm trying to demonstrate here is that I think everyone here knows the signs of shock. You know that whatever it is, you tend to have low blood pressure, right? And your heart rate will go up to compensate the low cardiac output. If you know that, just remember the opposite is what happens in increased intracranial pressure. And of course, in shock, you have what? You have respirations going up because your system wants enough oxygen. You have low cardiac output. You have less amount of oxygen bound oxygen bound hemoglobin moving around the body to supply tissues with oxygen. All right. So you have increased respiratory rates just to compensate for that loss. Okay. In Cushing's triad, indicating increased ICP, you have the exact opposite of what's happening in shock. So let us not forget. We have other triads and the rest. Beck's triad. This is just by the way, though. Beck's triad. Where will you find Beck's triad? In which condition?
Cardiac
Cardiac
tamponade.
tamponade.
Cardiac tamponade. Good. Someone is asking, what is cardiac tamponade, right? So that's where you see Beck's triad. And you can also search for that and keep it. So here comes my question. Unless someone has a question to ask right now. Any question from anyone? If not, let me ask my first question. Let's look at this. This looks it was almost a case study question, but let us look at how we can deduce our answer. Emergency medical technicians transport a 27-year-old iron worker to the emergency department. They tell the nurse he fell from a 2-story building. He has a large contusion on his left chest and a hematoma in the left parietal area. He has a compound fracture of his left femur and he is comatose. We intubated him and he is maintaining an arterial oxygen saturation of 92% by pulse oximeter with a manual resuscitation bag. Which intervention by the nurse has the highest priority? If you want to answer, you can raise up your hand here so that I call you. Is the name Nashi or Nash? Help me.
Yes, it's Nash.
Nash.
I think first we have to assess the level of consciousness.
Good. 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 I think we all agree to the answer. I'll not even call him for another. Yes. So, level of consciousness is very, very important. Okay. Level of consciousness is very important when it comes to neurological conditions. Unless maybe in very, very extreme cases. Most of the times when, or let me say, more than 70 or 80% of the times, maybe, yes, I'm sure, more than 70 or 80% of the chance. Whenever you get any neurological questions involving this airway and breathing and the rest, level of consciousness, wherever you have level of consciousness, always try and look at it very well. The answer could be that one. Okay. So try and understand the question and see. Okay. So we are correct. For those of us who want to read briefly, the rationale, that is it. Can we move on? Let's talk about another thing here. We have transsphenoidal hypophysectomy. Transsphenoidal hypophysectomy. When we say hypophysis, who knows what hypophysis is? Anatomy.
In the brain.
The pituitary gland, right? It's even on the,
Yes.
yes, it's even on the screen. The pituitary gland. So, talking about the removal of surgical removal of the pituitary gland, which is also part of the endocrine gland, and that stores and produces lots of hormones. The anterior part produces lots of hormones, and the posterior part, mainly antidiuretic hormone and oxytocin, right? The posterior one. All right, so most of the times when you get tumor, okay, or when they become malignant, that is where sometimes some of these procedures might be needed. But always know that this approach, transsphenoidal hypophyseectomy, you don't actually do craniotomy. You don't open up the skull and go into your brain. Most of the times it's done via the nose, okay? Where you have that's why it's called transsphenoidal. Those of us who remember our anatomy, our axial skeleton, right? The the position of the sphenoid bones. Mhm. So when someone goes for this surgery, all right, let's say there's a tumor of the pituitary gland and someone might need excision of it, okay, or hypophyseectomy, transsphenoidal hypophyseectomy. There are some concerns that we can address, okay? There are some concerns we can address. So let us look at some of them. The first one, we are saying clients undergoing hypophyseectomies are at risk for developing. We have lots of conditions that they can develop. Do you know that even some of the complications can be meningitis? They can have even wound infection. The brain and things related to the brain should be handled in high aseptic techniques. Okay. So the least breach in aseptic techniques, you are going to have an issue. Right. So some of the complications can have some as infection, which can even lead to inflammation of the meninges. And at the end, you can even get meningitis, right? If not properly maneuvered or done well, you can even have cerebrospinal fluid leaking as part of the complications involved in transsphenoidal hypophyseectomy, and lots of other things, okay? Like what we have here on our screen. So you are saying people can equally be at risk for neurogenic diabetes insipidus. That is a metabolic disorder of low antidiuretic hormone levels. You know what ADH does to the body, right? Anti means against, diuresis, or this diuretic comes from diuresis, which means urination, and hormone. So this hormone prevents you, it stores water, it absorbs water within the kidneys and makes urine concentrated. It doesn't let you throw away more water. Okay. So when you undergo this form of surgery as a form of complication, you can have it being affected. Okay. And one common complication of some of these, especially when the hypophysis is manipulated, whether by surgery or whichever, by injury, you can have these low levels of antidiuretic hormone. These ones are more common. All right. And what do you think will happen when you have low levels of antidiuretic hormone? That is where the condition diabetes insipidus sets in. Okay. Diabetes insipidus sets in. What is the opposite or a condition that can be linked to the opposite of DI?
SIDH.
SIDH.
Hmm? One person.
Okay, SIDH.
SIADH, right? Syndrome of inappropriate antidiuretic hormone. That is where you have overproduction of the antidiuretic hormone, right? Okay, so that is also for another. I think we did that one in when doing endocrine system, right? It was treated. Wasn't it treated?
It was treated.
Okay. So thank you. Let us look at clinical manifestations of DI. So this person will have decreased urine specific output. You know, so for those of us who struggle to understand what specific gravity means, take it as a concentrated urine. So the higher the specific gravity, the higher the concentration. If maybe it will be easier for you that way. Okay, and the lower the specific gravity, I mean, the more the urine is diluted. All right. So when you have, so in questions, the reader stated to you that maybe there might be decreased urine specific gravity, or they might indicate it with the lab value, right? If you have decrease in urine specific gravity, what's the normal one? 1 point what? The range. Who can help us? Urine specific gravity.
Less than 1 point. Oh, it's 1.3.
10, 10, 10, 30.
Like
Hello?
the range. Yes.
It's
10, 10, 10, 30.
10, 10, 30.
10, 10, 10, 30. Okay. Mr. Mary, I'll call you very soon, okay? I have some other questions here. Thank you. So 10, 10, 10, 30. So the 10, 10, we mean 1.010 to 1.030, right? So if you have, look at this value, actually, here is supposed to be 1, right? But you have it as 0. So that should tell you that the urine specific gravity value stated here is low, okay? So if you have anything less than this figure stated here, it should give you a clue that the urine specific gravity is low. And for that matter, the person is urinating plenty. Then elevated serum osmolality. Okay, what happens in DI is that you have free water leaving the system. You don't go with sodium. Okay, you have free water leaving the system. You know that in special cases, or let's say in most of the cases, where water goes, sodium follows. But this is one of the special cases. This is one of the exceptional cases where you have free water leaving the system, leaving sodium. So when you have sodium concentrated in the body, you have osmolality also going up. Okay. Then, like I said, hypernatremia. Because the solute to solvent ratio won't match, because you have more solute than solvent. Solvent is the water leaving the system. So your system will be concentrated. That gives high molality and also hypernatremia here. And of course, let us take note of the values. You know, it's 135 to 145 milliequivalent per liter or millimole per liter. Okay. Then you have hypovolemia because you are losing enough water. Then you can run into a potential hypotension. Because you are losing water, you can have polydipsia, you can drink more. Your system will crave for more, so that, I mean, you can have them replaced. But as you drink, you throw them away, okay? And you urinate plenty. So polyuria today can use, they can give you a value of maybe a very large urine output to just let you suspect or make you suspect that there's polyuria. So most of the time, if within 24 hours, they can urinate between 2, in serious cases, they can urinate between 2 to 20 liters per day. Plenty. All right. Any question? Before we carry on, any question? Okay. If no question, then I think we can carry on. Let us do lumbar puncture. Lumbar puncture. We are saying lumbar puncture involves removing a
Hello.
sample of, I didn't see your
Hello.
hand up. I didn't see your hand up.
Oh, I'm sorry.
Okay. Sister Gloria,
I
let us
didn't-
go.
Okay, so you said something like when they are urinating, the sodium is left behind. Why? And is that what causes the serum osmolarity or something?
I said in DM, sorry, in DI rather, you have free water leaving the system rather. Okay. And
Okay.
I made a popular statement that, where sodium or where water flows, you have sodium also flowing or following. Okay. But in this case, it's a special one. You have only free water leaving the system. Okay, when we talk about, let me go to that slide. When we talk about osmolality, think of osmolality as the solute particles in the blood. Okay, think of the solute particles in the blood, like these sodium, potassium, and all of that. Okay, these electrolytes and other chemicals. So any chemicals that are dissolved in the blood is what we are talking about here. Compared to, so it's like in chemistry, talking about solute and solvents. Use sugar in literal sense. Use sugar and or let's say salt and water as an example. Whether sugar and salt and water or salt and water. Okay. In this case, your salt becomes your solute and water becomes your solvent. So when you have a situation where you have free water leaving the system, okay, leaving, you are pouring out water, but the sodium is staying. So in this case, consider like a concentrated water with salt. When you put on fire, not plenty, okay? And let's say the fire dries out or burns out the water, leaving those whitish crystals in that utensil. You do that kind of boiling. I don't know if you are picturing. The water will leave the utensil, leaving that crystal, more of the crystal in the utensil. But in this case, you can't have, in our body, you can't have everything drying up completely. So what you are saying is that you have free water leaving the system. And, the amount of solute and solvent in the blood should balance. But in cases of DI, you have free water leaving the system. So you have more solutes, like these electrolytes being concentrated. That's even how come you have hypernatremia. Electrolytes of concern is sodium. You have more sodium because the amount of solvents, in this case, free water, that is should balance, okay, in the blood is gone because of the DI. So that's how come you tend to have concentrated sodium in you, leading to hypernatremia and also elevated serum osmolality. Do you understand this principle?
Yes, thank you.
You're
Yes,
welcome.
thank
All right. So back to Alama puncture. So if you have any question, please raise your hand here. Okay. So lumbar puncture, talking about lumbar puncture, we do lumbar puncture for several reasons. Okay. We are saying it is the removal or is the act of removing a sample of your CSF, yes, cerebrospinal fluid within your vertebral, or let me say, within your vertebral spaces, right? Like through your vertebral spaces. Removal of CSF through by the use of a needle, okay, through or in between the vertebrae. Which thoracic vertebrae is being selected? Between which thoracic vertebrae? Who can tell us?
Number.
Good, good, good. Thank you. I wanted to trick some people here. It's good you've said it. So you see, look at lumbar puncture. So it is lumbar. Okay, you got me correct. You got me faster. Wow, that's fine. So let us open our eyes well, open our ears when it comes to English. Small thing, the questions are not difficult, but small thing, you can be tricked. You see how I started? What's thoracic vertebrae? Someone said lumbar. So lumbar puncture, your lumbar vertebrae. So between L what and L what? You can have it taken from two spaces. Between L and L.
L3, L4. L3, L4, and then L4, L5.
Fine, good. So that is where you can do your spinal tap or your lumbar puncture. So we insert a long needle, the sterile procedure into your through your vertebral spaces into your vertebral column. Okay, that is where the CSF will be tapped. Cerebrospinal fluid, for those of us who have seen some before, you see how clear that fluid is. It's even clearer than a pure water. I don't know, from what I've been seeing. It is very, very pure and like crystal clear. Okay, whenever you get a good tap, devoid of blood and other substances, you should get it very, very, very clear, crystal clear. So elevated intracranial pressure is a contraindication to lumbar puncture. Let us take note of this point. See, we are just hitting on the point. Whenever you have an increase or you have a condition or a patient who has increased ICP, it is a contraindication. Okay. So the client is placed in the fetal position. You see, when a baby is in the womb, you see the position that the fetus assumes when in the womb. So that is what we are referring to as fetal position. Okay, and if the person is conscious enough to sit, not all patients who require lumbar puncture can sit. So if the patient is conscious enough to sit, then he or she will have to sit and lean over a table. Okay, so that, when you assume that position, it opens up your vertebral column down there. Okay, your lumbar vertebrae, so that the spaces can easily be accessed to reach your vertebral column. Okay. All right. We are saying continued leaking of fluid indicates that, after it has been taken or it has been drawn, when you continue leaking fluid, it means the side did not seal off well. Okay. Then we are also saying fluids are encouraged to help replace the cerebrospinal fluid. These things are produced in the ventricles, right? We have ventricles, 4 main ventricles in the brain. That is where you have the cerebrospinal fluid being produced. And you know that the spinal cord is a continuation of the brain. Sorry. The spinal cord is a continuation of the brain. So there's a linkage. Right from there, you have cerebrospinal fluid leaving the brain, ventricles flowing around the spinal cord within your vertebral column, okay, protected by, those levels, right? Pia matter, arachnoid matter, and the last one. Which one is it? Dura matter, right?
Dura.
Good. Okay. So after lumbar puncture, what do we have to do? We have to encourage bed rest. And this person should lie flat for at least 4 hours. Okay, some will say 4 to 6 hours. It's very good to lie flat so that you reduce your risk of any complication, especially headache is one thing that easily comes up. Okay. The first thing you are likely to report is extreme headache. So to prevent all these complications, we want you to lie flat. So let me say this one straight away. I wanted to ask in question, please, the position we are saying is flat. In questions, when you don't see supine and you see prone is correct. Okay, the idea is to lie flat. Prone is flat, supine is flat. We normally see lying supine after lumbar puncture without considering the prone. So when you don't see supine and you see prone, it's also a flat position. So it could also be correct. Okay. Up to 5% to 30% of clients will have a common complication like headache. Okay, like I said before. It is thought to be as a result of leakage of fluid through the dural puncture sites. That's the outermost protective layer over there. The symptom is treated and is normally self-limiting. It's not anything difficult. Like, it's not a worse situation, okay? And whenever the cerebrospinal fluid is drawn, we have to assess for color, content, and all of that. You don't just have to draw anything. And like I said, a normal cerebrospinal fluid is very, very clear and colorless, okay? And it also contains some proteins. It contains some proteins in it. White blood cells are in it, and it contains no red blood cells. So when you see cerebrospinal fluid tainted, okay, it means blood has mixed. And microorganisms are also absent in it. Though this is not, okay, Mr. Agnes, let me hear your question first.
Yes, sir. Please, I want to know why the CSF is always cloudy, because in one of the questions I saw that CSF, to me, I know it was clear, but in meningitis, I want to know why, and the rationale given wasn't enough in the answers. So please, can you explain that to me?
Why CSF in meningitis is cloudy?
Looks cloudy, yes, please.
Okay, so it's as a result of infection. Meningitis, we have 3 layers of the meninges. That is what we just spoke about, starting from the inside. The one that has a direct link to the brain and spinal cord is I don't know whether some will say pia or pia, pia matter, PIA. Then followed by the middle layer, the arachnoid matter, then the outermost parts being the dura matter. So when you have meningitis, you have these layers being inflamed. And they have direct link. So you can imagine the pia matter, if you have it inflamed, any particle or anything, it has direct contact with the cerebrospinal fluid. It is it's like its container in there. So if it is inflamed, any debris, anything, any infection, it is also within the cerebrospinal fluid. That is why when we are able to take a tap or a sample of the cerebrospinal fluid, we can analyze it and look out for causative organisms or microorganisms. We culture the CSF so that we will know which organism is causing that kind of meningitis and look out for an antibiotic to target it. So that is why it looks cloudy. Okay. Miss
Okay,
Agnes,
thank you.
are
Thank
you okay?
you. Yes,
Yeah.
please.
All right, that's Sylvia.
Yes, sir. Please, I want to find out if CSF, does it contain glucose?
Yes, I think it's stated here. Little glucose.
Oh, okay, thank you.
That is why when you have, let's say, basal skull fracture, you have rhinorrhea or rhinorrhea. You will have to do this. You have to test for it. I mean, glucose in the rhinorrhea to know because if it's just a fluid, let's say a normal secretion, a menstrual secretion, you will not have this glucose found in it. But if it contains CSF, you can have some rhinorrhea or some even nasal secretions, which can also look very clear. Sometimes they might mix with the nasal secretions and you can't tell. So if you want to be sure, that's why you do that glucose test to ascertain whether what is coming out from the patient's nostril is from a leak in the basal skull that is possibly CSF. Please, do you understand it?
Yes,
Okay, Mr.
please,
Jane.
thank you.
You're welcome, Mr. Jane.
Yes, please, I want to find out, for instance, if someone is having head injury or let's say meningitis, obviously the intracranial pressure is going to be high.
Yes.
So, how can we also do the lumbar puncture? Because we are saying that high ICP is also contraindicated for lumbar puncture.
Okay, so we always have to weigh, okay? Not everyone with meningitis will have, situations change or conditions change. Not everyone with meningitis will have increased intracranial pressure all round. Okay, it's like ICP is like any let's say any measurement. Okay, like let me use blood pressure as an example. Whenever, even among hypertensive patients or conditions that increase your blood pressures, like hyperthyroidism and the rest, there could be times where your blood pressures might fall normal, okay? But most of the times they might go higher in the rest. So situations change. It's like temperature. When you are spiking, doesn't mean you spike temperature throughout. So we have swing periods in between. Okay, and you can have someone with meningitis who is very conscious. Not all of them will be unconscious and the rest. So for academic purpose and also for medicine purpose, if there is an evidence of increased intracranial pressure, we have this probe in a very well constructed neuro ICU. We have these probes for measuring these ICPs and the rest. So you're always guided, okay? Invasive monitoring are there, you're always guided. So you can do it whenever you have a normal intracranial pressure. But it's contraindicated when you have intracranial pressure.
Okay.
All right. You're welcome. It's a Gloria. Old hand or new hand? Okay.
Please, I was asking, I don't know if I heard correctly, but then you said the CSF is
Cerebrospinal fluid, yeah.
produced. Yeah, is it produced in the ventricles or I heard wrong?
Yeah, I think ventricles. You can find out.
Like the
The brain has ventricles. So
ventricles.
come
Oh,
again.
pardon?
I think your network was breaking at a point.
Oh, okay. I was asking if it's the heart ventricles, like.
No, 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 no. The brain has ventricles. Okay.
Oh, okay.
Uh-huh.
Okay.
Yeah, so the brain has ventricles. I think there are four. So okay. Uh-huh. So that is where the CSF is being produced, not heart ventricles, brain ventricles. Yes, any other question? All right. So I think we can continue. So like we were saying, a normal cerebrospinal fluid should be very, very clear, devoid of any color. Okay. Then we have minimal amounts of white blood cells in it, but no red blood cells. So that means if you get a 9 stab, you shouldn't have any color red in it. Normal cerebrospinal fluid pressure is between 60 to 150 millimeters of water. This one, you don't need to memorize this. Abnormal cerebrospinal fluid pressure or content can help diagnose the cause of headache in complicated cases. So, cerebrospinal fluid is collected via lumbar puncture, or so you see, we have another one. How we can get the tap or a sample of cerebrospinal fluid, either through lumbar puncture or ventriculostomy. That's from the ventricles in the brain. But this one is more, they are all invasive though. I mean, minimally invasive, but lumbar puncture is easier because you don't want to, well, lumbar puncture is easier. Let me leave it that way. All right. So prior to lumbar puncture, you instruct clients to do the following. Empty the bladder before the procedure is done, okay? Then the procedure can be performed in the lateral recumbent position or sitting upright. So lateral recumbent, it's like you are lying your side, your knees flexed, like that fetal position we were talking about. So look out for the positions very well. Whichever way they explain it to you, do not let it trick you. Lateral recumbent. If you want to know how the position is, just Google it right now. You will see the position. All right. Or sitting upright and leaning forward on a hard table. And the main reason is to allow the space to open enough for us to have access to the cerebrospinal fluid. Right. So you're seeing a sterile needle will be inserted between the L3 to L4 or between L4 and L5 in that space, like we said. Pain might be felt. Pain may be felt radiating down the leg, but it should be temporary. So watch out for abnormalities. If pain persists, this radiating pain or shooting pain even worsens, it's a cause for alarm. Okay. After the procedure, instruct the patient to lie flat with no pillows. So you get a question like, which of the following statements from a patient who went for or let me say that who went for lumbar puncture requires intervention or a follow-up, and patients say that I can sleep with a pillow, okay, with my head raised up to allow me to breathe well. You see, pillows are good when your head when your head is elevated. It helps with breathing well. But with this perspective, you should not allow that because of the procedure the patient has gone for. So I always say that on NCLEX, even the wrong answers will be well nourished. If you have experience here, you can attest to it. the wrong answers are well calculated for. So when you are getting it wrong, you get it wrong with confidence. Okay. When when it's like failing is difficult, passing is also difficult. So you choose whichever difficult way you want to go, whether passing difficult or failing difficult. That's why we have to take note of some of these things. They polish the wrong answers, and you don't just put the correct answer there and make the wrong answers very, very, very different for you to be able to spot it easily. So always shine your eyes. And like we always advise, if you want to be best, those who practice it, it has been helping them. Okay, sometimes we do give ourselves excuses of workload and some household chores and the rest. But please, we know we are sacrificing, but let us do it and do it well. Whenever you are doing your test, any test you are doing at all, whether from your personal question banks or from our dashboard, and you are about to do questions, sit down and do it as if you are doing the Meningitis. Give it all your attention. And we say practice makes man perfect. It will work. If you are here and you cry over low scores and the rest, you start, doing these two things well. Because let's say you went to work, you were tired, you came home, you think you still want to meet deadline, so you do your test. Do you think you will score as much as when you were relaxed? And when you get low marks, so you will cry. And you'll be like, what are you not doing well? Like, some of this comment that we pass. It is okay to get some questions wrong, from the beginning, because we are learning, okay? And whatever question that you get wrong today, when you review, well, should you see similar or same question tomorrow, you get it correct. So that's how we improve. So let us do it well. Open your eyes well to questions. That is my plea. Do it now. Let it be part of you, so that when your time is even getting closer, you'll not even struggle, not even a bit. Okay. All right. So we've also talked about the fluid intake for at least 24 hours to prevent dehydration. All right. I don't think we have question here, or someone has a question. But I have a question for you.
Sir.
Yes, sister. Let us hear you. You didn't raise up your hand here.
Oh, sir, sorry.
Go ahead.
Sir, is there no
Hey, Timothy, is it your surname? Okay, you go ahead.
Sir,
Yes.
please, is there any way like they will give anesthesia before the procedure?
Anesthesia doesn't require anesthesia.
Okay.
Yes, anesthesia. I don't think it requires anesthesia. Okay, your eyes will be open. You explain procedure to patients that there will be pain and the rest, but anesthesia, no, I don't think so.
Can I say
The reason
this?
why I'm
Okay.
asking that is
Sorry.
when they are doing bone marrow, they give ketamine to the children before
In
they
medication, yeah.
before they start the bone marrow. So that was why I was asking if they give anything before the lumbar puncture.
Okay. Okay. Lord wants to tell us something.
Yeah, so well, anesthesia, it could be in the form of local. It's a form of anesthesia that they've given. So they could do a local infiltration before they push in the long needle.
Okay.
So anesthesia could be possible depending on whoever the patient's situation is.
Okay. Thank you for that
Okay.
addition.
Yeah.
So if anything, it should be local, not generalized one, or not general anesthesia. And with bone marrow thing that you said, bone marrow, you are drilling into the bones. And yes, of course, that one I know you need anesthesia. But yeah, so it's exactly as our brother said, okay. Maybe a local one. Even sometimes when it comes to IV insertion, especially among older people. Sometimes you will have to give them some small lidocaine and the rest, whether cream or something before you give. Thank you for that addition. Any other question or inputs? If not, I have one for you here. A nurse is caring for a client's post-lumbar puncture. Sister Sarah, you want to answer?
No, I wanted to ask a question. So initially in the slides, you said we should increase fluid intake, and then I think the last point over here too, you said increase fluid intake. But I've observed lumbar punctures being taken, and the meals they take, they are like less than 20 mils or 10 mils. So how would that one cause the dehydration?
Yeah. So, I don't know whether I should ask this funny question. Do you know the amount of water that will be required to produce just a ml of a ml of cerebrospinal fluid? You know, it's a different, I mean, it's a different fluid, okay? And remember, you have some small blood, those loss of blood and the rest, like at the sites, you know, whatever happens, there will be some few leakages and the rest, but you can say that they are insignificant, but you will still, as long as you are drawing, you are removing direct water from the, especially cerebrospinal fluid from the body, you will still need a replacement. No one knows amount of water that will be needed to produce. I mean, the body will need to put, but the body will produce the cerebrospinal fluid from the blood. So blood will go into the brain. That lining, I've forgotten that lining, the ventricles, that will help produce the cerebrospinal fluid. It will all be taken from the blood. So you definitely need replacement. Even if not much, you will still have to hydrate small. Not like in veins, but at least you have to be given some small hydration. If you can drink, you drink. Okay, if you can't drink and you are MPO, we give you IV, maybe saline. You get it?
Yes, please. Thank you.
Okay. So this question, a nurse is caring for a client post-lumbar puncture who reports a throbbing headache when sitting upright for meals. Which of the following are appropriate actions by the nurse? Select or that apply. So you see how you answer questions. The first part gives you an idea what's happening. We are caring for, I mean, you are the nurse caring for a client's post-lumbar puncture. The client reports throbbing headache when sitting upright for meals. So what will you do? Who wants to try? Okay, for the select or that apply questions, let's do it together. So the first one, use the Glasgow coma scale when assessing the clients. Do you think it's necessary here? Do we have to
No,
do it?
Oh,
Your reason?
no, client is conscious.
Okay, okay. And there is no indication of change in level of consciousness, right? Good. Option
Yes.
B, assist client to eat meals while lying flat in bed. Do you think this one is necessary?
no.
No.
It can cause aspiration.
Are you sure? Okay, so this is not my handwriting. No.
Is it even possible at all to lie flat in
You
bed?
you see,
Oh no,
uh
oh, I'm just
when
asking over.
when you have dumping syndrome and it's
Hmm.
in extreme cases, what position do you assume when eating?
You lie flat.
Okay, let's carry on. Option C, Do you think we should administer opioid medication?
Yes.
Yes.
Okay. Encourage clients to increase fluid intake. Is it necessary?
Yes.
Place clients in a cannonball position.
Yes. Me, I don't know this. Okay, no.
So you choose,
No.
you decide not to choose what you don't know, because select or that apply questions are +1 - 1, right?
Don't know it all. What is that?
Cannonball position. All right, so
Hmm.
we all do
Let's
we all
consider
agree with CD?
option B. Let's add option B.
We should add option B. Someone is saying we should add option B. Okay. So between CD and BCD. All right, so let us check our answer. So yes, we are correct. BCD. Our BCD people are correct. Okay. So if only the client is hungry and want to eat, because considering, you see, this client is conscious enough, though there could be a risk for aspiration, everything is possible. This client or this patient do not have an already existing risk of aspiration, and this patient wants to eat. This patient cannot sit up and eat. Okay, so what will help this patient? The patient can lie and eat. All right. Then the rest, I think we don't have any issue with the rest. I have another one for you. And this is caring for a client who has experienced traumatic head injury and has an intraventricular catheter for ICP monitoring. Okay. The nurse should monitor the client for which of the following complications related to ventriculostomy. So ventriculostomy, that is when you, making an opening into the ventricles in the brain. So we've inserted the catheter in there and connected it to a monitor to monitor the intracranial pressure in there. And we are saying in a setup like this, this ventriculostomy setup, what is the possible complication? So this is the question which has been reframed. Who wants to try? Let me see a hand up. Who wants to try?
Hello.
Mr. Rich, you didn't raise up your hand. You want to
Hello.
try?
Yes. Yes, please. I will take infection.
Your reason?
I said I'll go for infection.
Your reason? Can you hear me? Hello?
Yes, I can. We can hear you.
So I'm asking you, why do you choose infection?
Yes, I think it's an invasive procedure, and infection is bound to happen.
You don't think headache can happen?
No, please.
Hypertension. Not even a face here. All right, let me take some other options too. Thank you. Yes, who else needs to try?
Hello, sir.
Others.
I've raised my hand.
Okay.
Sir,
Yeah.
I'll take the headache because it's the ventricles that has been affected, and looking at the CSF, there is the ventricle in the brain that the fluid is produced. So I think I'll take the headache.
I like your explanation very, very well. But are you looking on your screen? Okay.
I too sepsis because I was thinking that the procedure is an invasive procedure. And once it's invasive, the likelihood of infection is high.
Exactly. Exactly. So the answer here, Mr. Idris, you want to talk here?
You know, this one, they were asking for the complications.
Good.
You know, the headache is like a sign of
It's a normal sign, expected sign.
So I think the infection is the correct option.
Okay. Thank you. Thank you. Please, as we go through this, I hope most of us are learning one or two things, how we deduce answers. It will help a lot. So when you involve yourself, think it goes a long way to help you. Right. The answer is infection. Now, we have a question here. This one is about Glasgow Coma Scale, GCS. Let's see how we do it. A nurse is assessing a client for changes in the level of consciousness using the Glasgow Coma Scale. The client opens his eyes when spoken to, speaks incoherently, and moves his extremities when pain is applied. Which of the following is the correct scoring by the nurse using the scale that indicates the client has a moderate head injury? So if you are here and you are not used to Glasgow Coma Scale, you'll find this question difficult. GCS. Someone should calculate and let's see what you get.
Say A.
You had
So
A.
yes, please.
Which is 10, eh?
Yes, 10.
Okay. Who else? What are you getting for I? The client opens his eyes when spoken to.
So to speak. So to speech is 2.
So wait, let's look at this thing. One easier way to do GCS.
I is 3.
We have EVM, okay? Like EVM this way. Mr. Gloria, I want to try here. Your hand is up. You
No,
can
I was just saying if you could
With
just
the
take us
eye,
through it quickly.
we are
Oh,
taking
okay.
with the eye. We say when you open your eyes spontaneously, you yourself, you are sleeping and just woke up. That's 4. If you open because I've called your name, that's 3. If you open because I've instinct pain on you, like I've come to tap you, that gives you 2. But if I what is it? Upon tap or instant pain and you don't open, then I give you 1. So I think the client opening by voice is under 3.
It's
So it's
3.
3.
Good.
Yes.
Good. What
His
about
answer is
verbal?
B. It's 4.
Verbal to we say that
Verbal is
Verbal
who
is
is
4.
if
I'll
she's
show you something
orientated.
here. Okay. You can go ahead.
It's okay unless I organize my bet. I think when you're orientated to you then that one gives you 6.
Okay.
But if like the client is a little confused, verbal. I forgot it, unless I write them down. Sorry for
Okay, let's do the motto. Don't worry. Let's do the motto. What do we get for motto? And moves his extremities when pain is inflicted. When pain is inflicted. I think that is also 4.
that gives 3. That one is 3.
Are you sure?
4.
That is
That one
4.
is 4. Yes,
Pain
4.
is 4.
Yes.
For the three would be that extension.
Abdominal flexion, yes.
Yes, abdominal extension. And the two will be when you move your body close to yourself, right? All right, so I think the answer is 3. So the answer is B.
Yes.
For most people who are able to even sort out the I first, I think you saw right away that the answer would be what? B. On the English, you can get very close answers. Maybe 2 of them with E3. Okay. And then maybe they will change only one. So you'll have to know it very well. Okay. I think I have something here for us. Yeah, so the answer is B. 3, 4, 4. Let's take a look at this one very well. Just to wrap us up when it comes to GCS. Okay. So we have verbal response, eye opening response, then motor response. So you can see from here, for eye, we have a score of 1 up to 4. We have 2 people with their hands up. So is that Gloria? Your hand is up. Then after that, Bra Isaac. You want to ask a question?
No.
Okay, then Brother Isaac.
No, I wanted you to take us through the
Oh, go ahead, sister. Go ahead.
Sister Gloria. Okay. Then
Okay,
Isaac,
I
you
was just
can.
finding out. Also, I was just finding out if you can share this form, probably later. The form, not the slide. The form.
The form, like what you see here. I can't understand
Yes,
what you're
yes,
saying.
yes.
You said
It's
you want
the
this one, eh?
yes, this form, the form, the
Oh,
GCS score form. Can you
okay.
say?
After class, I'll drop them. Okay.
All right, then. The form is
I'll drop
okay.
them in the pages.
Okay.
I think in the master class page, yeah, I'll drop it so that we
All
look
right.
at. All right.
Thank
So, and I think we shouldn't even spend, you see, over here, you just have to sit down and try and analyze it so that it sticks forever. Okay. At a time, you might try to forget some and the rest, but yeah. So this one, they are standards. Okay. They are standards. So I'll do it that way. I'll drop them later when we are done with class. So let us carry on. So another question here. A nurse is assessing a client who reports severe headache and a stiff neck. The nurse's assessment reveals positive Kennex and Brzezinski signs. Which of the following actions should the nurse perform first? You see the thing? Client reports headache and stiff neck. Please raise up your hand if you want to talk, okay? The nurse's assessment reveals you have positive Kennex and Brzezinski sign, right? Which of the following should the nurse perform first? So answer it secretly as if you're answering English question. Sister Agnes, your hand is first here. You can unmute. You are muted.
Okay, please. I'll go for B because it's a sign of meningitis.
Okay, thank you. Sister Abigail. Oh, you dropped your hands. I need all your answers.
Oh, I was about to say I'll go for B because I'm
Okay.
suspecting meningitis.
Okay. Who else?
Okay, with the A, you have to what? Ascertain the cause of the stiff neck before you can start what? Antibiotics. So you have to do
Okay.
your lab investigations. Then the B, you have to implement your droplet precautions because the meningitis is a droplet kind of listen. It's an
Okay.
infection that requires droplet. The initiating IV access, after you have ascertained, like you have already established the isolation barriers, then you will not can now start your IV access. Then the next the client what a decreased bright light, because light what will trigger or seizures and other things to occur. So my answer would be
Okay. Okay. So I think it is true. Okay. It is true. We figured it out earlier. So when we say connect sign, I hope by now everybody knows what connect sign here. I mean, I hope everybody knows what connect sign is. When I think it is positive, when you flex the patient, let's say when the hip is flexed at 90 degrees and upon extension of the knee, patient complains of pain. That is positive for Kenneth sign. And with the Brzezinski, it has to do with the neck, right? When you flex the neck, the patient will flex is it the hip or the knee? The hip, with the knee. Yes, I think both of them will also be flexed. That is how to also ascertain Brzezinski sign. So both of them, even if you find one, you suspect meningitis. And you know meningitis, as soon as you suspect it, unless it's been ruled out, please, whatever thing you are doing, even when you are at the emergency department and they come and you suspect any form of disease that needs you to take precautionary measure, please do it before you do anything. What I mean by anything is, even if the patient is in severe respiratory distress, unless it's airborne, as soon as you have reason enough, please isolate this patient before you start treating or doing something for this patient. Okay, so that is the extreme part of it. And it's like, I think I've said this before in life class, it applies to chemical burns too. When you are, let's say, at the emergency, or someone comes to you, soaked in severe, maybe serious chemical and the rest. The first thing, even if the patient is having severe respiratory, depression or distress, please don't say you are going to give oxygen and you are going to do all those things to help patient breathe well. You end up dying with the patient, in quotes. Okay. And you will be, you will be, let's say, a vector. You can even be a vector to carry harm to other patients you are also caring for. So whenever, because let's say if you are caring for 3 patients or you are caring for 5 patients and one has, let's say, a contagious disease, you attend to the patient, you go to the next patient again. You can just imagine all of these. That's why it remains your priority. Isolation, as soon as you suspect something, isolation should be your first measure. And for those of us who are playing with the basics, these isolation precautions and these basic things, fundamentals, critical care, these fundamental things that you should know. Please be careful, because sometimes you see, we will think of these big things and we will find the small ones and we can't answer them. Okay, you hear maybe parvovirus, you see parvovirus before you, and you can't determine whether you should put this patient in let's say a droplet precaution isolation room or an airborne. You won't know, and all of that. Okay, so let us pay attention to all of this. They are very important. Don't wait until you are left in a tight corner before. So you are correct. Think we have the next thing here, if no one has any question. We are come to talk about epidural hematoma. So epidural hematoma is an accumulation of blood between the skull, bone, and dura mater. So I think we have we have a diagram here. You can see. So let me pick my pen. Here is the skull. Okay, the skin is on the skull. So this is the bone, the calcaneus, right? I mean the ossified bone. Let me say that, not calcaneus. Calcaneus is your heel, right? Your heel bone. So this is a skull. You have so this is the meninges, the colored part from here to this layer. Okay. So these are the meninges. The first layer is the dura mater, as you see labeled here. Second layer is the arachnoid mater, the middle layer. Then the pia or pia mater is this. So you see over here, you have cerebrospinal fluid all around. Okay, all around here. Then you have the brain also in it. Okay, so cerebrospinal fluid, it lubricates the brain, and you have you see, this is the brain tissue itself, and the pia mater is just surrounding the brain. So this subarachnoid space sometimes allow let's say if there is should I say a swelling, okay, maybe a minor one, you have some form of small accommodation. But when it becomes extensive, that is where you see that, pressure in ICP, I mean, increased ICP symptoms, blood vision, headache, and nausea, vomiting, all of that. All those complications coming. So what we are seeing here in subdural hematoma is you see, this is the dura mater, right? This is the dura mater. So when you get a bleeding, let's say upon concussion or let's say a head-on injury, and you get pool of blood collecting under the subdural area, that is where you see, the brain itself has a space. Okay, let me use this one. The brain itself has a space. Their allowance, like I said, if there are situations, sometimes your brain will have to swell, maybe temporarily. Okay, maybe in benign infection or something. And these small spaces allow for that. Whenever there is any external something, let's say you have this subdural hematoma, it also creates a space here. And increase is like you have a bag which is already full, and you want to force something big into it before you close the bag. You see how the pressure within it becomes. So that is what happens in the brain. So whenever you have any hematoma, any form of hematoma, anything that leads to bleeding in the brain, okay, you tend to create a high pressure within the brain because something has been added in the cranium, which it shouldn't be there, and it is adding up to the pressure in there. So that is how you get your increase intracranial pressure symptoms. I don't know if you understand what I'm trying to say. Are we clear? So let's see what we have here. Epidural hematoma is, so we have subdural, we have epidural. All these hematomas, like I told you, depend on the area. Okay, subdural is under the dura mater, epidural is on top. Okay, and all of that. But the thing is, epidural doesn't have a direct link with the brain, because looking at this one, you see this is the dura mater. So epidural will be between the skull and the dura mater. Epi means up, above. subdural will be down. So that one will have an issue with the brain. Okay. So this is subdural. But I think what we are talking about is epidural rather. So know the difference. Okay, subdural, that's under the dura mater. I'm repeating myself. Subdural under the dura mater, you get a compression within the brain, which will affect level of consciousness. It will affect intracranial pressure. But epidural mater is where you have the collection above or out at the outer part of the dura mater. Okay, so between the skull and the dura mater, as you see here. So what do we have here? We are saying the majority of epidural hematomas are associated with fracture of the temporal bone. Okay, fracture of the temporal bone, which is part of the skull, the bones that make up the skull. And subsequent rupture or tear in the middle meningeal artery. The bleed is arterial in origin, and so hematoma develops quickly. Okay, so you see, still, so let's say the clue here to this kind of hematomas, whether epidural or subdural hematoma, is that you see these meninges, they are still delicate. Okay, they are not hard or osseous like how the skull is. They are not calcified. It is only the skull which is hard. The rest are just, I mean, they are just membranous layers. So even when you have, let's say, a pool of blood collecting under the skull, like epidural hematoma, and so collecting between the skull and the dura mater, you still have a pressure created in here, which will have a rebound effect on the brain. Because remember, we've opened all of these things to be, I mean, we've widened them so that you will see, but they are very thin, okay, and very close to each other. They are very thin. The only hard protecting part is the skull. So when you remove the skull, all these things are just membranous layers. So even when you have a pool of blood, like the epidural hematoma you're talking about, between the skull and so where I'm shading, and the dura mater, you see, the pressure, the bone is hard, so it will not go in to accommodate the blood. It will rather push the pressure in here, and it will decrease the pressure here. Okay, so whether subdural, epidural, any of the dural hematomas, they will end up affecting the brain, give you ICP, decreased level of consciousness, and the rest. Okay. So let's see what we have. We are saying the clinical presentation of epidural hematoma is characteristic. Okay. The client may lose consciousness at the time of impact. The client then regains consciousness quickly and feels well for some time after the injury. So so this is called the lucid interval or the lucid period. And I said it earlier on. And sometimes when you get head injury, immediately you feel not all the time. Okay, sometimes. Some people will just encounter the head injury and I mean that will be all. But some people will get lucid periods or intervals. Okay. Where everything patients, initially patients will lose consciousness, then after regains consciousness, the patient will talk fine, everything will be okay. Okay, and the patient might even be discharged home. The patient might even be discharged home for some days, as we discussed in the slides when we were doing the head injury. Okay. So this period is called the lucid interval. It is followed by a quick decline in mental function that can progress into coma and even death. So when now everything starts declining, it declines rapidly. So subdural hematoma and epidural hematoma, they will give you similar signs and symptoms. I mean, similar neurological symptoms. They all end up affecting intracranial pressures. They will give you blurred vision, and you lose consciousness and all of that. They'll give you all those signs. So let us take notes. If you have any question on this one, we can bring it before we carry on. If you don't have any question, I have a question for you. Can we do my question? The first one. Okay, Mr. Jane, your question.
Yeah,
Can
same.
we are listening.
Person is well, the person will now get into coma. Is
Please,
there any?
I didn't hear the first part, the earlier part. Sorry.
I'm saying.
Hello. Please, is it my network or is from her? Can you hear me?
Yes, please.
It's from here.
Oh, okay. Mr. Jane, I don't know if you can hear me.
Hello, I can hear you.
Yeah, your network was breaking again.
Okay, so
it's gone again. So can you write it in the comment section? Okay.
I was. Hello.
Yeah,
I was asking that, is there any physiology behind it that a person is involved in an accident and then is well discharged home and then later get into comatose stage and then things get bad?
Okay, so if I got your question well, how does the lucid, or I mean, why does the lucid period happens? In short, right? Or how it happens? Is that your question? Okay, so let me try and give this explanation if it will answer you. That is if only you can hear me. So when you get that impact, because it's a fresh one, you know, the brain will be shaking. Okay. The brain will shake. You go off. For that one, it is okay for you to go off when the brain shakes, like unexpectedly. You go off, but some of these let me say responses, okay, to the impact that you've had, some of them are not quick. They take their time to develop. The brain has been injured. Okay, so it is undergoing changes, some changes, and you know, inflammation changes and the rest. So when there's a direct injury, like a high impact, like head-on collision or anything that gives you this condition, I mean, after the brain has been shook, you get this loss of consciousness, you come back. But remember, the brain has been subjected to some kind of injury, and it now has to undergo some form of inflammation. Okay, I want to relate it to something common. You see, when you get, let's say, a scar, should I say scar? Okay, let me say when your body gets bent with, let's say, a hot iron. Have you seen that sometimes, let's say if the iron did not burn your skin completely, all right, did not maybe erode your skin or something. Do you know that around that instance, even sometimes, depending on the extent of the burns, if you pour water on it and after cooling, I mean, after you do your everything, you can have that place intact. Though you have the pain, but you have the place intact. But the following day, or maybe subsequent time, you have the place becoming swollen with fluid-filled vesicles. Have you realized that?
Yes.
Good.
Mhm.
So you can understand it in that sense. Okay.
Okay.
When the brain has been subjected to that injury, it takes time for the inflammatory response to happen. And when it starts, that is where everything declines sharply.
Okay.
So if you understand it that way, relate, I think it will be better.
Thank you.
You're welcome. So let's look at this first question here. The patient who has a head injury is diagnosed with a concussion. You all know concussion, right? Which action will the nurse plan to take? Let's say you've hit your head on a hard surface. You've been diagnosed with head injury. Which action will the nurse plan to take? Who wants to answer? Let's Abigail. Let's go.
I will go for D, to arrange to admit the patient to the neurologic unit for observation for 24 hours. We just learned that when the thing happens suddenly and they awake from unconsciousness, everything will be normal. But after some few days or period, they'll go back into altered consciousness, which may lead to coma and can even cause death. So I think this patient should be admitted for observation.
Okay. Who else wants to try? Thank you. I like your explanation. Who else wants to try? Richmond, you want to talk to us? Your network is not helping. Your network is not helping.
Let me also try.
Yes, any other?
Hello.
Your network is breaking, Richard. Richmond, sorry.
Yes, please.
If you can write it for us, your network.
I
Any other person?
For yes, please can you hear me?
Any other person? Yes, Tama, you want to talk?
Yes, sir.
Okay, let's go.
Okay, so I will go for C. Transport the patient for an MRI.
Okay.
So to ascertain the extent of injury to the brain before any other of if then it will be on the basis for either your admission or discharge of the patient, and then teach the person how to monitor any changes in the neurological status.
This is an interesting question, eh? All right. I get you. I like your explanation too. The last person. Who wants to try? Last person. Okay. So, thank you all for your inputs, but the answer is B. The answer is B. So you see how the necklace will trick you. Remember we said lucid period is not, those who were choosing D, it's not necessarily 24 hours. So why keeping the patient there? I mean, patient who is not actually, though there could be a sign of, not everyone with concussion or a head injury, or let's say an impact, will have the lucid or we even have any neurological complication. We are saying that the lucid period is possible. Okay, and some even occur within 2 or 3 days. So if you understand this idea, take this case to be like a real case scenario. Let's say you are the doctor at the ER, you have this case before you. Are you sure you're going to look at your patient, this adult's face, and tell the patient, I mean, with respect to your medical knowledge, that you detain this patient for 24 hours. If this patient goes home, lucid period is also possible in the next 48 hours. And even in the next 72 hours, it's possible. So if you keep the patient, why don't you keep the patient for all these periods where the lucid period is possible? So why 24 hours? So this is more impractical. If the patient, you do your assessment, please, those of you who were, let me say it in relation to C, the person has been diagnosed already. So why choose a diagnostic answer? Because this one will help us diagnose. The person has already been diagnosed. Okay, so once this person comes, you run your test, everything is fine. With the lucid period, even before that, those who normally show the lucid period, that instant MRI or any scan, these are imaging scans. They will show a normal brain because the brain hasn't started changing. Okay, so everything will be fine. And if you currently have evidence that everything is fine, in this case, you can let patients go home, but not just going home. Okay, you provide discharge instructions about monitoring neurological symptoms or status so that they can come back as soon as they see them. So option B is more ideal than the rest of them. Think about it well. Okay, let's read the rationale. So let's read the rationale briefly. So you see, can we carry on? All right, let's carry on. So that's the rationale, okay? So you see, I'm sure all of us might admit that this question isn't that difficult, right? But you saw how easier we had it wrong. It's very, very easy to get it wrong. So that is how the enclaves will look like. Okay, similarly. Let's look at another question here. This one to lose very easy. And for this one, I believe everybody will get it. We have a patient who is suspected of having an epidural hematoma and is admitted to the emergency department. Which action would the nurse plan to take? Who wants to try? It's quite easy, right? Hey, no one wants to try. Okay. Come again.
I will go for C.
Type and cross-match blood for transfusion. Why will you go for C?
I'm thinking that the patient, because of the hematoma, HB will be low.
Okay. Okay. Hey, then this person will actually bleed, right?
I'll go for A.
So what would the furosemide do? You see, when you pick the answer, you ask yourself, what would the furosemide do? will it absorb the right now? We all know what
No,
epidural hematoma is. So you ask yourself, is the furosemide going to remove the epidural hematoma, that blood pool, okay, around the epidural link?
I took lazies for dexamethasone. So sorry. I thought it was dexa when corticosteroids just to decrease
the swelling,
swelling.
inflammation and
Yes.
swelling.
So sorry for that.
Okay, so let's say if there was a fit answer like Dexa, you would have chosen that one. Eh?
Yes, please.
Okay, thank you. Any other? Okay. Okay, so let's carry on. So what we have here, you have a blood pool or a pool of blood at the epidural space. How this one will cause issues when you have pool of blood. Blood shouldn't stay there. How can we get the blood out of that epidural space? Because that blood will not live there automatically. What can we do to help?
Do a bear who?
Craniectomy.
So it's craniotomy. Straight away. You have blood in there, it will cause issues. No drug will make that blood to become what? To become dried, or it's not like like small cysts where you can give some antibiotics for those cysts to go away or something like that. You have blood occupying the epidural space. You have to remove the blood. Craniotomy.
Boss, question.
Yes, you can
So,
ask.
what's the purpose of suspected? Because I anticipated a possibility. It's not confirmed. So I was a bit
Okay.
in a difficult situation to
Okay.
choose.
So a patient who is suspected of having an epidural hematoma is admitted to the emergency department. So you see, we don't have any information apart from the epidural hematoma written here. So, okay, let us consider this suspected still to be, so it means it's 50-50, it's possible, right? So whether even on a 50-50 scale, do you think A, B, C will be better than D?
No, that's why I didn't choose it. Well, I only chose the A because I took it for Dexa. Had it not been the
And even if there was a Dexa, or any steroid, steroid won't do anything much.
Okay.
The amount of space that the blood can occupy, looking at the strength or how the steroid will act on the brain, you can't have that.
It's insignificant.
Yes, it can't counteract. So you will still need a craniotomy. That is why
Thank you.
with epidural hematoma and subdural hematoma, they always go for borehole craniotomy. Just that big girl. And you see, most of them, they will be admitted like with loss of consciousness and some extreme headaches and the rest. As soon as the surgery is done and everything goes on well, they are okay. After recovery, they are okay. All right. Just that big girl, you can ask your question then.
I just want to be sure that means in epidural hematoma, the management is craniotomy.
Yes, you have to
Okay,
remove the blood.
thank you.
That's your priority. You have to remove the blood straight away. Okay. Mr. Idrisu.
Yes, sir.
Mhm.
Within the brain, I'm sure thrombolytic cannot have effect over the.
Thrombolytic. Hey,
Yes.
yeah, you worsen situations when you give thrombolytics. So, hey, like seriously, it's 100% contraindicated. You are going to cause more blood.
Clots.
Remember that bleed over there came from a severed vessel.
Yeah. And because it has
Okay,
become
which
hematoma.
bled into any thrombolytics you are giving, you are not infiltrating it in there. You are giving it via IV.
Yeah.
And you already have a possible severe brain. You rather flatten the patient's brain with lots of blood, and the patient will die. Like it's like you've actually killed the patient.
Okay.
So it is similar to like giving thrombolytics in hemorrhagic stroke. That's how it looks like. You know what that will do. Uh-huh.
Yeah.
Okay. Hamdia.
Thank you.
You're welcome. Hamdia, you can ask your question.
Yes, I want to, it's like a question of classification that I need. You know, sometimes the question, if you are not very sure of it, you try to use the elimination method.
Mm-hmm.
Yeah. What I realized about this endless questions and answers is that some of the answers, it's like, I'm new here, so I'm getting confused a bit. Some of the
Oh,
answers,
okay.
like I administer IV furosemide.
Uh-huh.
As a nurse, I don't think you can just get up and be administering IV furosemide
Close
without
mind. Okay.
doctor's order. Or some
Okay.
of these endless questions, do we work like we are on our own? Can we administer things or do things without any doctor's order?
Okay. So I get your question. Okay.
Sometimes some of the questions are like that. I get confused whether to find myself
Yeah.
as a nurse or whether you understand. Yeah.
Yeah, I understand you. It's because you are new. Okay. So let me say this on record. So when you get questions like this, okay, sometimes they'll add administer prescribed. Okay, they'll add prescribed, then they will add the medication. But there are times to, even if you don't see the prescribed, and let's say you see how this question has been stated, it's like an implicated prescription has already been made. Always take it that way. Okay. Most of the time it's like we are looking out for some questions will be like we are looking out for a medication that will be useful in that sense or that situation cited before you. Not You will not be concentrating on whether you, the nurse, you are doing it out of your own without prescription or something. Okay. So most of them is like it's implicated that it has, I mean, those drugs have already been prescribed.
Prescribe, okay. Okay,
So you
like
can
like
apply that to a lot of questions and see. Okay. They
that means
are,
that the patient has
uh-huh.
already that means that the doctor has already ordered you the nurse to prepare the client for. You should assume that the doctor has ordered for
Yes.
a
Yes.
tracheostomy.
So that's why I want to use the word implicated. I don't want to use assume. Okay, so okay, let's say literally you assume that all the listed medications have been prescribed. So which one will be useful in that scenario cited before you? Do you get it? You get it, eh? Your voice goes low and
So,
comes up.
okay, so I should assume that whenever I see, I should assume that it has already been prescribed or it has already been ordered. So whatever you
Yes.
are doing.
Yes, you try that. It works for most questions where they want you to concentrate, where they want you to concentrate more on whether it has been prescribed or not. You will see it in the question. You see something like maybe a collaborative something, or I've seen we've done one question here in live class before. You will see the question to be very different. You see this one, the main aim was we were targeting epidural hematoma. Okay. So in questions like this, whether they add administer IV like prescribed IV furosemide or they do not bring the prescribed. I mean, assume as it has been prescribed. Okay. Even look at the answer. The answer that we chose: prepare the patient for immediate craniotomy. Will you do that on your own?
No. Please, another
So you
person.
see, most of them are just implicated. It's like we are supposed to do all of this, but which one would we do first to help the situation?
Oh, okay.
You get it?
Yeah, I get it. I get it.
Okay. Any other question? So that's our rationale. Okay. Craniotomy. let us finish with some few questions. All right, please, we have about 1 or 2 more questions to go. Let us quickly do it and go, okay. While admitting a patient with a basal skull fracture, the nurse notes clear drainage from the patient's nose, right? Which of these admission orders should the nurse question? This one is clear. This one is clear, yes. Who wants to answer? Sister Abigail, your hand is up.
Insert an nasogastric tube.
Yes. I mean, we will not even spend lots of time here. NG tube. You know, basal skull fracture, your base of skull, I don't know if we can picture it. How I'm demonstrating it here. It's as if you are even watching me. Your basal skull fracture, right? Whenever you have let's say a fracture that affects this part, you know those signs, right? I think we did that in part 1 in our first meeting. That's raccoon eyes, okay, or periorbital hematoma, okay.
Battle side.
You have battle sign, that's bruising around the ear, okay, the back of the ear. All those signs are signs of basal skull fracture, and you tend to leak cerebrospinal fluid from your basal skull part, and you know it is linked to your nostrils. So you tend to get this kind of, that's where I mentioned this rhinorrhea thing, right? And that when you get someone with basal skull fracture, if you suspect, you have to do this glucose test for it. And sometimes you can also do this halo test, right? The halo ring test, or do you remember that test? Where
Yes.
you put some of the sample on a dry gauze and see, especially when it is mixed with blood, when it is tainted with blood. Okay. You drop a sample on a white gauze, then the blood will be concentrated in the middle. Then you see a halo ring, like a ring layer around the blood. Okay, like a clear fluid around the blood in the form of ring. So that is how, especially, so we use that test to test for CSF when it's mixed with blood, right? Then when you have a clear fluid coming from the nose, you can use the glucose test to test for proteins. Sorry, glucose rather, not not proteins. Though the CSF contains proteins, but you test for glucose rather. Okay. So if it contains, pure nasal secretions do not contain any glucose. Please, we have a special meter for it. Don't go and pick your word glucometer to go and check. Okay. You won't get anything when you do that. So that's why it's NGT. When you set NGT with someone or in someone with this basal skull fracture, you might end up pushing the NG tube into that break, okay, through that breakage in the base of skull that has been fractured. And that will push the catheter into the brain. You cause lots of worse issues. So you don't do that. So that is our rationale.
Please, can you go back to the question again for me? Thank you.
All right. So that is it. So let's take our last question and break here so that we continue, God willing, tomorrow. The nurse obtains these assessment findings for a patient who has had head injury, right? Or who has head injury. Which finding should be reported rapidly to the healthcare provider? This is easy to spot, don't you see? Which one are we taking?
Hello.
Yes, you can try.
A, you know the
Yes.
normal urine output is 30 mils per hour, and this one 800 mils there is too high. Meaning, the hormone that is supposed to
Okay,
concentrate
I understand
urine.
you. I understand.
That's where I'm
Yeah,
going.
yeah, I understand. So, when you have questions like this, okay, when you see maybe urine output of 300, 400, please don't be concerned too much. Let's say per hour, okay? Those areas are still monitoring phase. Though we give, you see, like our sister said, 30 mils per hour. Please, the 30 mils per hour is a cutoff point, not a measuring scale that, I mean, everybody should produce around that amount of urine per hour. Okay, so even with the 30 mils per hour, what you are saying is, even if you are not producing urine at all, it shouldn't be less than 30 mils per hour. So if at a point in time, if someone is producing 300, 400 per hour, we still monitor. We can't actually depend on 300, 400 mils of urine in the past hour to tell that the patient is having DI. Can't do that. So they will give you abnormal, most of the times they will give you, let's say from 600 going. Some questions I've seen, the least they can give you is 600. Okay. So let us stick with 7. Okay. All right. So the answer is A. If you have any question, you can ask. If God permits,